So I have the honor and privilege of introducing our next speaker. So Rachel Ramirez is the Director of Health and Disability Programs and the founder of the Center on Partner-Inflicted Brain Injury at the Ohio Domestic Violence Network. She focuses on supporting professionals and systems to develop brain injury-aware, trauma-informed services and systems. She provides extensive national and international training, technical assistance, consultation, and program support. Rachel has co-authored several peer-reviewed journal articles and has been featured on National Public Radio, as well as the New York Times Magazine and the Washington Post. And I have been honored to be able to work and be friends with Rachel for the past number of years. And my ad lib to this bio is that she's the one that always shows up. She's the one that supports all of us and has really, truly changed the landscape for treating and supporting IPV-related brain injury in the United States. So it's my absolute honor to introduce you all to Rachel Ramirez.
Thank you so much, Carrie. Thank you. I have this like weird lighting, and this is like too bright. The other one's not bright enough, but so glad to be here. And I don't know if it's like a pro or con to be. It is 3:30 my time, and we have been at this for a long time, and it's been a lot of days with a lot of thoughts. Some of you might also recognize me. I don't know who's been here for the whole day, but I also talked with Survivor Paula before lunch, if anybody remembers, back to 3 hours ago, because we've had so many just important learnings, important understandings. I think one of the things I am going to, and some of you had an opportunity to do this, but I also just want to better understand from you all kind of where you are. We're going to have an opportunity to interact again one more time, and I'm going to pull up my fancy dancy new little tool that I've been using called my Menti, and I'm going to publish this for you. And I just want to hear from you. This is actually very kind of easy to be a part of, but you'll see that there is a code on the top. You can go to menti.com, put that code in. You can scan your QR code. I just want to hear from something, everything we've heard today. What is your most important learning today? What is something that has really stuck out to you? We've had voices of researchers, we've had voices of survivors, we've had voices of people who work directly with survivors. And it's really cool. I think that, and then your answers just pop up. So whoever put survivor voices and experiences, I always say, if you see your answer show up here, go find yourself. If we were at an in-person training, I would get a bowl of candy and you get some candy. So go get some candy somewhere. And just take a minute to look at all of these different things, talking about testing, how to better connect between sectors and agencies, brain injury screening. I want to know how, as a physician, how I can better support survivors, to not be dismissive, learning about functional neurology, wraparound services, bring OTs into the shelter, symptoms of brain injury after IPV or domestic violence, connection and collaboration. So please feel free to keep we know we have an RF, so we now know what RF means. We have a research facilitator for the North Dakota Brain Injury Network. North Dakota, I think I just talked to someone yesterday. I might be making a trip out there at some point. So thank you all for sharing that. Just thinking about everything that we've done today, but what I really see a lot of themes here about what people were learning and what people were sharing is the role of survivors and the role of survivor voices. And I'm going to go ahead and kind of move over to my PowerPoint. I think that, Carrie, I think that this is very much validating how important it is to start this whole process by really listening and centering those voices of survivors. But thank you for doing that. I now feel super, super confident. I also know how to use these Menti things in training. And just to give you a little bit about myself and my background, I come at this from maybe a different perspective. A bunch of you all here. I don't know how I muted. Okay, I just said I was muted. I got my toolbar on top of my PowerPoint that I'm trying to share. But so I work with the statewide coalition on domestic violence. Many of you might know that there are domestic violence coalitions across the country. Every state has a federally recognized one. Some of them are coalitions, joint coalitions with sexual violence, where there's a domestic violence and sexual violence coalition that is one organization. Some of them are separate and have sister coalitions. In Ohio, we have a domestic violence coalition called the Ohio Domestic Violence Network, and sexual violence coalition called the Ohio Alliance to End Sexual Violence. And we work closely together. But I just want to help you. I think one of my roles and my jobs in here is to help everybody kind of understand the domestic violence infrastructure and the domestic violence landscape and what our services look like. I am a social worker by training. I had my first job in a domestic violence shelter in 2003, 2004, quite a minute ago now, working in an 103 bed shelter in Tampa, Florida as an advocate, and have been at ODVN at the statewide coalition doing statewide work on domestic violence for 17 years and counting. So I think that one of the things around this brain injury and domestic violence piece, and I'm trying to bring the domestic violence service perspective into this and really thinking about some of that engagement with survivors and also that engagement with the brain injury system and what it is that has looked like coming from the domestic violence perspective. But in my 17 years, I will tell you, very, 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 very honestly that it was, I had been in domestic violence services for almost 13 years, including leading in a leadership role at a statewide organization connected with lots of national organizations, and had never once considered nor thought about brain injury in its connection to domestic violence. And I had spent many years, I think one of the pieces that I think needs to really, really be emphasized when we are understanding some of the unique flavor and the unique considerations of this type of intersection of the violence and the brain injury is really needs to be centered and needs to be started from a framework of a trauma-informed practices or trauma-informed care, trauma-informed approaches perspective. In many domestic violence, we have been working on trauma-informed practices and trauma-informed approaches for decades. I always like to say, I think domestic violence might have invented trauma-informed care before it had a name, because we have always talked about where, of course, there are ways in which people struggle after abusive relationships, and it's not because they're crazy, it's not because it's your fault, it's because somebody hurt you, it's because of what happened to you. And this is where I was living my life at my agency. This is just the definition of when we talk about trauma-informed care and what that is. So from anybody who's coming from the brain injury perspective, and even people coming from the domestic violence perspective, or whatever you're bringing in from the medical perspective, this trauma piece is really at the foundation of this work that we do. And it's really at the foundation of all of the additional collaboration building, all of the additional community partnerships, all of the services, and even our personal interactions with survivors has to come from this place of trauma, which is one of the pieces that is so unique about violence. But we know that trauma, so I was in the middle of, I spent from about 2010 to 2016 leading a trauma-informed initiative across the state with our 76-member domestic violence programs, who serve, this past year, sheltered about 9,700 survivors, including 3,800 children, but provided services to almost 100,000 individuals across the state of Ohio. So that's something else to recognize, is shelter is one very critical and important piece of our services, but most domestic violence programs provide exponential number of services to survivors not in the residential setting. But I was working with my programs to better help understand, what does it mean to work with survivors who have experienced often the chronic, the ongoing, and the really, really severe psychological trauma that was just a part of almost everyone who approached our services experience. So we know that the trauma-informed approaches, we actually have a manual that is available online. I will try very hard maybe in the next session to get a link to that direct manual that we published originally in 2010. But it was really about the hands on the ground. And we weren't trying to work with one program. We were really trying to think about our network of programs, our 76 programs that we have in Ohio, that we also know other states have their programs. And how are we recognizing the impact of trauma, those signs and symptoms? How are we responding with sensitive services? What does it mean about knowing what trauma is and how that impacts people and how they respond and how it impacts thoughts and in behaviors, in access and engagement and their relationships with us as helpers. And we need to integrate that while very intentionally resisting re-traumatization, resisting any way in which happens with domestic violence survivors all the time. You don't have to work with domestic violence survivors long to understand. And we've heard the very, very painful experiences of re-traumatization from the survivors on this conference today. So I was tootling around the state doing this piece, had some pretty, done some pretty extensive work with systems, and we ended up getting a grant. We ended up writing a grant, and it was actually, I think that this is what we're coming from this perspective of trying to figure this out on the ground in real time with some of our programs, but also what lessons are we learning for all of our programs. But we ended up writing a grant about how we could better support survivors who are experiencing mental health struggles, which is one of the number one mental health and substance use behavioral health struggles is one of our strongest challenges we have in domestic violence services. Something that agencies are constantly trying to figure out how we deal with that, how we address that, how we know that mental health and substance use can be strongly correlated with domestic violence, particularly because of the mental health coercion, the substance use coercion that happens. So we had our agencies telling us we need help with this. And then we threw this piece on brain injury in there, partially because we didn't know anything about it. For any of you who write grants, it was kind of like, this is a little bit different. And maybe the people who review this grant, like, it seems, and like many of you are like, it seems kind of obvious that like we could be working with brain injury, right? Because since my first day in shelter in 2003, I have been talking to survivors, and survivors have been openly sharing with me about their experiences about being hit or hurt in the head, being choked or strangled. Made a lot of sense. But even in our national network, we weren't ever at we didn't know people. We actually had, as Kathy was talking about, we had enough of a relationship with our Brain Injury Association of Ohio to get a letter of support for that grant. But it was very surfacey. Applied that grant, and then, as many of you know, then you go off and you keep on working with your other stuff. And a few months later, found out that came through. And I think that one of the things we really do need to start any kind of work that we're doing by listening, whether it is listening to survivors, whether it is listening to the staff at the agencies that we're engaging with, whether it is listening to the perspectives of the other professionals when we're trying to build this response that involves people in so many different spaces and so many different places. So and I am also going to give a special shout out and acknowledgement to my research partner, my partner in crime, Dr. Juliana Nemeth, who has had some recent health issues and is not able to be with us today, but she is my partner in crime, came from the practice world, went into the academic space, and really helped us think through in this very, very practice grant. I had 3 years to come up with some way, how do we better serve survivors with brain injuries? We don't know really what brain injuries are. We don't know how it impacts people. We don't know what our network knows about brain injury. We don't have, this wasn't a project. I know we've talked a lot about those connections with, neural resource facilitation or with the medical provider, or kind of what all of those things look like. We didn't have any of that. We were really thinking about, this was almost, I would say like a quality improvement, quality QA/QI initiative. How do we make our programs better? How do we make our programs more accessible? How do we make our staff better prepared to work with survivors who are impacted by mental health or brain injury? And I think that that's also been a key learning for us. I do think that it is very valuable with some of the excellent conversations we've had today about screening protocols and referrals and getting people connected with neuropsych and resource facilitation and these different parts. But something we were also very, very insistent on is helping domestic violence. People who work at domestic violence program understand understand, like, this is our work too. And this is work for me to do. This is something that is impacting my relationship with the multiple people that I'm working with every day. And so what do I need to do differently? And what does this look like in my setting, in my space? So we took it through a public health planning process. We did a needs assessment where we learned, just like many of you have learned, that 86% of the survivors in our network at the 5 programs that we work with had been hit or hurt in the head. About 49% said they didn't even know how many times. 83% had been choked or strangled. So it was just an incredibly, and I think most domestic violence, people who work in domestic violence are not surprised by those numbers. They are a little shocking to kind of actually see them, but I've never trained an agency, a domestic violence agency, who was unaware that head trauma was a significant issue for the survivors that they were working with. So we went out and we talked to survivors and we talked to agencies. We actually didn't talk. I'm going to reframe that. We started listening to survivors and we started listening to agencies and really asking those questions. Just like we say with a direct service perspective, our job is to listen to survivors and then help them with what they are telling us that they need. Not come in with a whole bunch of ideas about what I think you need and what I think will help. Start from the survivor's perspective. We started that perspective from our programs, and we talked to our programs and said, look, what does this look like? And what does it, what does it look like? And what are your challenges and how can we help? And what do you think would make us able to help support you in your programs becoming more accessible? So the big picture was, I mean, and this is again, that staff were pretty much completely unaware, just like me. They were not recognizing how often, and we weren't recognizing the impact. Going back to those trauma-informed frameworks, we did have an administrator tell us, I mean, I've been here 28 years and we've truly had only a handful of true TBI clients. And we had lots of staff many who had spent years, some of them who were newer, but had spent decades in the domestic violence service space, who were really thinking about brain injury for the first time. We had lots of concerns, but one of the things that we really realized is that we missed in our trauma-informed frameworks, which trauma-informed frameworks, again, are the bigger bucket of all of this work. We've missed that repeated head injuries and strangulation leads to brain injuries, that intersection. But again, it's not, I don't know if this is the best word for it, but a lot of times we talk about it's not like clean is not the word that I want to use, but I talk a lot about brain injury plus. Yes, it's brain injury, but yes, it's also serious safety concerns. Yes, it's also concerns with my children. Yes, it's also housing issues. Yes, it's additional medical issues. Yes, it's mental health issues. Yes, it's a lot of just kind of insecurity about, where am I going to be in the next month? Yes, it's a lack of social support, which is something that we've learned that brain injury is often so predicated on. That brain injury services can be very, very difficult to get into access if you don't have that social support, which was just our reality in domestic violence. But the consequences of head trauma and strangulation had not been a part of that conversation. And that was something that we really wanted to partner with our agencies to better understand. I think that they were also concerned about all the complex conditions of survivors and how can I help and what is this to do with? And we've heard that from many people saying, well, who do I refer them to? And what is it that looks like? And what am I supposed to do? And one of the things, as I said, I was almost really glad, I think in hindsight, that we didn't have this like partnership that was built into it, and that we told domestic violence program staff that, all right, ask a few questions or do a screening around brain injury and then refer them to this place. Because we've talked so much about the challenges related to access, we've talked so much about how much domestic violence survivors had on their plate. And this was about, you can help, and we need to help in ways that will actually, like brain injuries interfering, not just, we're not trying to fix the world here. In the domestic violence space, we work in a very, very imperfect space, and our services are very, very imperfect. And we do the best we can with what we've got. And we have amazing advocates and amazing programs who are just fighting day and day to do the best they can with what they got. But so what can we actually do to help? how am I empowering domestic violence advocates and all professionals that interact with domestic violence survivors, that there is something that you can do to help. I wish brain injury was as simple as it's this problem, you screen for it, we identify it, we send it to somebody, they fix it, they come back to us, and we go about our life. I do think that domestic violence programs were uniquely positioned, though, to start to take this work and own this work and embrace this work because we've worked with trauma for so long. And when we think about trauma and traumatic stress and extensive traumatic experiences, we don't expect somebody to come in with traumatic experiences. We send them to the trauma person. The trauma person figures all that stuff out, and then they come back to us, and then we can go on about our lives. We've adapted our services. We've changed our services. We've developed new partnerships. We've done all of that kind of stuff. But our agency, our network of agencies was telling them that we need training, we need simple stuff. We are also working with people who are often unstably housed, who have been through recent traumatic experiences, who have other coexisting behavioral health or physical health concerns, who are trying to figure out things as basic as housing, things as basic as custody of their children. We're trying to figure out all of that stuff. So our tools need to be simple, and we need support, technical assistance. I wish we had that named a different way, but technical assistance or program support, they needed support from us as an agency to help them figure out how to do that. So what we really went about is we went about creating a trauma and brain injury informed framework that didn't kind of put those two pieces together. And I always talk about it. And also, we wanted domestic violence advocates to feel empowered to be able to take on some of this stuff. And we know how to do work with trauma. We know how to provide services and adjust our services and provide those individualized services with survivors. And we're enhancing that trauma-informed framework to include that brain injury awareness. We can't lose that trauma piece because brain injury and trauma are gonna be like this for that is what the characteristic of this issue is. So we developed our framework called CARE. CARE is an acronym for connecting, acknowledging, responding, and evaluating. And it really was, how are we bringing that brain injury awareness to trauma-informed approaches that we have been practicing for so long? And how are we focusing on even just the awareness, the basic awareness that brain injury could be one of the considerations helping people that are impacting people and their ability to access our services from like this, the point of entry to be able to get into our services. How does brain injury impact that? What about the accommodations and what about the accessibility? And it really is meant to be a flexible framework. When we talk about, as we know, trauma-informed approaches have to be flexible, but we're connecting with survivors by forming those relationships. We've talked so much about that relationship building and that key part of relationship and rapport building with people who have experienced interpersonal trauma. How has it become our job to acknowledge how head trauma and mental health challenges are common? The key role of providing information and education to survivors. Now, we're not diagnosing concussions or brain injuries. That is never going to be our role. That is never going to be our scope. But having people know, I heard Kathy talk about how many domestic violence survivors, it's a lot to think about, but it's also, we heard Paula talk about, we heard some of the other survivors talk about being able, like, I know I'm struggling with something and I know it's real. And I have been told that I'm crazy, and I've been told that I'm stupid by my partner, and I've been told that I can't do things right. And now I'm having all these problems doing that stuff. But being told like this stuff might be real. I've been gaslit. I've been told what happened to me didn't happen to me. I've been gaslit by my partner. I've been gaslit by helpers. I've been gaslit by family friends. I've been gaslit. We heard a lot. Paula talks about the gaslighting by the medical community, by being told, no, you don't know your body. You don't know what's happening. So that information and education to survivors. And then how are we identifying with you? What does that look like for you? What is that looking like for you? What are your challenges? What are your struggles? What is getting in the way from your perspective to getting what you need? And I think that we had a lot. I know we've talked about occupational therapy. I know we have a good occupational therapist. A shout out to Christina, who really did some great work around this. We've been texting throughout the conference all day talking about things, but really helping people get back to what they want and what they need and taking that from their perspective. How are we responding by accommodating those needs? This is a framework based on accommodations. We might not be able to get people into immediate care. We might not be able to get things diagnosed right away. This might not be what is on the top of survivors list, which is totally fine. It is very, very hard to take care of a chronic condition that you have maybe experienced and lived with for a very long time until you can figure out, am I safe? Am I going to have somewhere to live? And are my kids are safe? But how are we responding and making sure so that, guess what? My potential brain injury or my trauma or my cognitive impairment or whatever that is, my memory problems, isn't getting in the way with me not being able to get housing, or isn't getting in the way with me not being able to get that protection order that I need, or with me being able to comply with a case plan with children's services. So we're accommodating those needs. And then we really are thinking about the effective, accessible referrals, which is a tricky one because we really do need trauma-informed providers. We need providers that are not only comfortable with brain injury, they're comfortable with domestic violence. They are aware that brain injury can be a consequence of domestic violence. They understand how trauma manifests itself. They understand that survivors have had really bad experiences talking about this. But then we're going back in and we're evaluating those accommodations. So if we tried these strategies to help you sleep, how are they helping? Are they actually helping? Are they not helping? And if they aren't, that's fine. That's a part of the advocacy process. We are continually going back in and checking back in what's new, what's different, what's changed, what do we need to do in a different way. So that was our framework with CARE. And I think one of the biggest perspective changes that we got, that we learned from our advocates who are working in programs, was when we thought about this is something that I've learned straight from the brain injury world. Kathy, I've had a lot of opportunities to work with the wonderful Brain Injury Alliance in Nebraska, who've done some real groundbreaking work on this. But it's the brain injury people that have talked to me about, are we working with survivors? Are we thinking about things from a won't or can't framework? I had a James, who is in Iowa. I was just out doing a summit with him, works in child welfare in Iowa, taught me something years ago that I'd never forget about how explanation drives our intervention. So why we understand people are or aren't doing things really, really drives how we respond. And when we are thinking about things, another way of talking about won't versus can't is really the skill versus will. Is it that somebody just won't follow our rules or won't show up on time or won't engage with us? And if they wanted to, they could. If they cared enough, they could. If they set their priorities enough, they could. Or is it that maybe because we have not set up brain injury aware frameworks, maybe they can't? And maybe we need to support and help and do things in a different way. Maybe it's our job to make our services accessible. So we all know that brain injury impacts survivors' daily activities. It impacts service access. It impacts ability to engage with us. It impacts housing and legal systems and participations in services, which again, this is why we were telling our programs, like, this is our stuff. Yes, we do need partners in this area. And yes, we do need collaborators. And yes, we do need to build a system of care, but this is also us because we're trying to help people get housing and we're trying to help people manage their legal services. And we are safety planning with people and we are working with people around caretaking. So we developed a set of tools that are available at odvn.org. There's a /brain. They are all free. Most of them are translated into Spanish because that was the other thing our programs told. They said we don't have anything that's easy to understand. The little concussion fact sheet from the Ohio Department of Health for youth sports isn't all that helpful. But we also heard is that we needed flexible tools. So it wasn't about developing one screening that we used all the time with people. It was about sometimes screening or sometimes a formalized, form where there's yes or no answers make sense. Sometimes it's really providing people information and education. And sometimes it's when I'm in the middle of a conversation and someone's sharing with me about their experience with violence. As I've developed that relationship, as I've built that connection, I'm saying, well, what about, has any of that violence ever been directed at your head? Can you talk to me a little bit more about that? Because one of the things that we're learning is that we know, like, our brain is in our head, and we know that our brain, kind of thinking about how are we having those conversations. So we think about the care tools as like a toolbox, and sometimes you need a hammer and sometimes you need a saw. And we have people who are in shelter services where we have weeks or months to work with survivors. We have legal advocates who see one survivor for 10 minutes and will never see them again. We have people who contact our hotlines again and again. We have people who call us once. So recognizing that our approach to raising awareness and providing information and education, that acknowledgement, we have to have lots of different tools to do that. And there's a lot of ways to do this work right. I did want to also mention a tool that we have called Chats, which is more of, I resisted for years and years calling this a screening, because I do think that a lot of what we needed our programs to understand is that this is something that requires us being involved in this process, us talking about this process, us being able to make, again, provide some of those educational tools, think about how this helps us with accommodations. So this really being something that can help us think about referrals, but that also can help us think about how we can better serve survivors. So, and it has questions like I talk about brain injury plus, there are questions about choking, strangulation, overdose and oxygen deprivation to the brain. We're learning more and more about thinking about the integration of substance use, how substance use can cause brain injury. We have questions about after you were hurt, alterations in consciousness, the trouble a survivor's experiencing, the desire to seek additional care. We added additional pieces that we just thought were very important from a service provision perspective around suicide, substance use, and other health issues. And in our initial research with Chats, and there's a guide. I think that's the other thing, that one of my challenges with some of the screening tools that I had seen around brain injury is it doesn't help me know what to do. And so we developed a guide for advocates about like, well, what do I do? Like if somebody says yes to these things, is there anything that I can do? Because yeah, maybe I need to connect them to a doctor, but I don't have a doctor that's trauma informed. We don't have that infrastructure. The survivor doesn't want to be connected with the doctor. They're trying to figure out their housing. What is that? But we really talked about, it has guidance for advocates on that role of education and health literacy and providing them with information about what to do if people had recent violence, what to do if people had repeated violence, what to do if people talked about suicide, substance use, or other health problems. Again, recognizing how does brain injury impact all of those pieces, with a focus really on our accommodations and our internal. So what does that mean for my work with you? What does that mean for our agency's work with survivors? And also some of those referrals that might be necessary. But again, thinking about the accessibility, thinking about the comfort level that our providers have in addressing the trauma, the domestic violence, the mental health, and are accessible with all the survivors and the different social determinants of health challenges that they're having. This is just a very little bit of research. When we talked about Chats, these are just the things that survivors told us when we did interviews with survivors. I do think that it is particularly telling that 11% of survivors, this was one tool we used in a very, very long interview, that 11% of survivors told us about they're having thoughts of suicide. So, our Chats tool says if somebody talks about suicide, we're going to stop all of this stuff. We're not going to figure out the brain injury stuff. We need to follow our protocols related to asking questions and doing that suicide intervention. But we looked at some of these things. People with alcohol or drugs, people told us that they're having problems with anger and rage and worries and fears. And then this really helped us figure out, how do we work with survivors? So what does that mean if I have somebody who is coming into my services, coming into my shelter, coming to stay with me, and they're telling me I am really struggling with anger and rage? What does that mean? I want to work with survivors different. How are we going to plan for that differently? How are we going to, if we have somebody who has a problem with remembering things, they're going to have a ton of appointments. So how are we coming up with strategies? How am I accommodating for that needs? What we heard about CARE is that CARE, we had an advocate that tells us has really changed the way that I advocate for my clients. It has been an incredible tool that I use in all aspects of our work. So in 2019, we founded the Center on Partner Inflicted Brain Injury, recognizing that this intersection is unique and it's different, and bringing in the domestic violence piece and the brain injury piece, really that there was a need for leadership around the specific understanding of what it is that looks like. We do have a webpage. I do a ton of training both within Ohio and around the country, but it really is also talking about support for resources and developing some of those collaborations. In 2020, we got one of our first federal grants. Our first grant was actually from 2016 to 2019, and managed to put some stuff in some different grants for a year until we secured a federal grant. These are all practice-based grants funded by the United States Department of Justice Office on Violence Against Women's Disability grant programs. And the grant program was really, and all of our funding to this point has been through the disabilities door. But the grant program, the collaboration on strangulation and traumatic brain injury survivorship was founded. And our goal, the grant program, is really to increase collaboration and develop training for providers and services for survivors of domestic and sexual violence. And how we defined what COST was is an inclusive, strong, interactive network of deepening and evolving partnerships among collaboration members focused on bringing diverse and historically disconnected fields together. So that was originally funded and still is a group. We are in our 4th year of our grant work together between the Ohio Domestic Violence Network, the Forensic Nursing Network, and our Brain Injury Association of Ohio. We heard Kathy talk about the Brain Injury Association in her state, with our vision being every survivor of brain injuries caused by sexual or domestic violence assaults in Ohio will have accessible, trauma-informed, culturally relevant support and services needed to live their best life possible. So we had this grant that started with ODVN, with us trying to figure out, this was an in-house grant, like we need to figure out, like, how are we making sure people just get access to domestic violence programs, that brain injury does not interfere with their ability to get access to our member programs. But we quickly realized we needed these partnerships. So we expanded some of those partnerships. We developed some additional tools. We have an informational card about what to do after you've been hurt in the head, neck, or face, with some warning signs, with some information, again, starting to say brain injury and domestic violence in the same space. And some of the things that we can think about as service providers, what do we need to do? We also, this has been very, very popular. It's actually a business card. I think you can see it here. It just says being choked, strangled, or hurt in the head can cause a brain injury. And on the back, there's a QR code to a web page. It says on the back, getting help can save your life. Learn more by scanning the code. And it takes us to a survivor web page that we wrote very, very intentionally, that has information for survivors. Every single word was thought about very carefully by myself and my colleagues about help to know what is a head injury. It's got a little video about what is a head injury, because we know in common terms, there are survivors that can have problems with reading, trying to have different ways for people to get access to that information. What are 10 things to know about DV and brain injury? What are some common challenges, and how do you get connected to resources? We then had the opportunity, Juliana, my research partner, is in one of those pictures, that I have been in Ohio doing this work for a long time and talking with everybody we knew about this work nonstop for years. So in 2022, we got some funding from Ohio State, this research practice partnership that's become so valuable, and held 2 community conversations in 2002. And really just like invited everybody we know, like, who wants to have a conversation on brain injury from domestic violence? And we had people in the room that had never been together. It was really like, this is the fancy research part. We kind of, and again, how I would describe it from a practice professional is, we got a whole group of people together and they said, we need to have an alliance. So we said, okay, let's do that. But we really developed it by some qualitative and quantitative data for these community events, and really thinking about, this is what we're trying to do in our group as we're meeting. We're addressing existing barriers to seeking care. We're increasing culturally relevant and trauma-informed resources and services. We have practice strategies to empower survivor. We're thinking about our organizational practices, and we're really explaining training, education, tools, and screenings to improve awareness related to this intersection. I think I'm going to skip over some of this. Is all the research stuff that we don't have time for. We had a lot of research today, but I just wanted to show you, this is just an example of people who came to one of our meetings. An incredible breadth and depth of different partners, of different community partners, and people funders. We have the research people who have never met the practice people. We have the strangulation people who don't know the concussion people. We have the healthcare people who don't work with the justice system people. We have the DV people and the human trafficking people, and really being able to come together as a group and meet to just better understand and address this whole issue of brain injury from violence. So it is chaired by ODVN and the Ohio State University, and we have a very fancy mission and vision statement. We had the group vote about what our vision statement is. I wanted this very first line that says statewide alliance to better understand and address brain injury from violence, which I think is a nutshell in what it is. But we have over 60 organizations partnering participating, as well as survivors and friends and family. And we're really focused on raising awareness as well as training, multidisciplinary collaboration, research services, and that on the ground responses. We have 2 in-person meetings with a virtual follow-up. We have 2 virtual meetings. And it just has been an amazing opportunity to be able to bring people together, like literally in a room that have never been together. I think the other piece that has been so important and so critical has been, we do have a small group of survivors, and we have a survivor group that really has space at every single meeting that they want it, really focusing and better understanding those voices of survivors. It has been something that we have learned a lot from that process about also even just what it feels like for a survivor to come into a space like this, where you have a lot of people with a lot of experiences and a lot of titles and a lot of letters behind their name, but really just encouraging and supporting survivors. Nobody knows more about brain injury from violence than a survivor who has experienced it. So this has just been, the last meeting we had was focused on healthcare. We're going to be focusing on the justice system this next meeting. So I think that there is really so many opportunities for our next steps, where we talk about, we have quarterly meetings with different topics and a strong focus on networking. I have people who are, we've talked about, I remember we had a person who came to our last meeting who does science, does rat like rodent research, and then we have like an advocate who works at the prosecutor's office, and they're like, we have never been in the same room together. But really that topic, and again, deepening our understanding of domestic violence and brain injury together and bringing all of those different perspectives in different places. We really are also trying to develop champions to raise awareness within their spheres of influence. We have state government, we have the Supreme Court of Ohio. We're trying to get our I don't know if informants, like our undercover agents, into all of these different places, because our first job is really to raise awareness that this is even, we can't do anything until our agencies are aware that this is something we even need to address. And really, again, supporting that opportunities for survivor leadership and education to better understand and address this. So that is, I think that my, I know I'm at 413, and thank you for going with me on that very, very quick journey through our work in Ohio. But I will tell you, in November of 2016, if you were to ask me, what does brain injury have to do with domestic violence, I would have said, I don't know. That's something that is in football. I didn't know what any signs of symptoms were. I didn't know what anything was. Very, very grateful for my brain injury partners in Ohio, including the Ohio State University, Dr. John Corrigan, who is really a eminent leader in the in the brain injury field, and has been a mentor and a friend. And I think that there are opportunities for all of you to look at your community partnerships and start to really start having these conversations, start bringing people together. And that's how we're going to be able to move forward. So I'm gonna close my mouth and see if there's any questions.
Yeah, that was a great talk. We do have a couple of questions, and we have a couple minutes to be able to answer them.
Okay. Am I looking in the questions that where I'm supposed to look for them, Carrie?
The first one's in the Q&A, or I can read it to you.
I think I saw Dr. Nemeth. So I'm going to answer the last one real quick because it's short and I can answer it quickly. I will say, on our website, online classes regarding head trauma and IPV victims, we do have on our website, which is www.odvn.org/brain. There is a link. We have a 7-part series of an online learning series, which is really mostly aimed for our domestic violence advocates. Each session is about 10, but meant to be about 10 or 15 minutes long, because we're real busy in shelters and DV programs. So you can pop on and do some of that stuff and then come back. It is free. You just have to create like a login and a password, gets into our e-learning system. We also have an incredible depth and breadth of domestic violence education and information on a plethora of topics. So please take advantage of that if you have any DV people or non-DV people. I think that that's, all of us need to be DV people, just like all of us need to be brain injury people. I think that that when we talk about I wish Juliana was here, talk about the role of chats in research. I feel like this is maybe a little bit, I'm going to try to play a researcher for a minute, but on TV, but I don't know how all I'm going to do. I think that there are important, I don't know. I feel like I should kind of say, I don't know. But I think a research survey, I think that just understanding where chats came from, it really came from a direct service provision utility. I think that there are very opportunities to use it in research. I think some of the challenges, I actually really created chats. It has not been validated. To be honest, we hardly have anything that we use in domestic violence that is validated because there's very little funding to validate things, and things change and we learn, and we do some of those things so much and so differently. But I think that we did need something to be brief. And Sam, maybe we could follow up and talk a little bit more about that. It actually was created because there were challenges I think helps is a great tool. I think helps just has some holes in it though. And I think that I really also would like to I think I really also wanted direct service providers to feel like they had something that they could do about it. It really was a tool that was meant to help us increase access. And I know Carrie says, Carrie, please feel free to take that one on, because I'm like, ooh, this is where the research practice partnership. My answer is always sure, but I'm also the one who reads the journal articles and skips over most of the methodologies because I don't understand it. So maybe you might have a better answer, a better thought than I do.
Actually talking about this tomorrow in the keynote.
Okay.
A little bit, tiny bit.
Little
But
teaser for tomorrow.
yeah, but I think many of the questionnaires that we are using do need validation. Lots have been used in the research setting, and we're working to try and get those all validated. So if you do want to use it, just know that you need to make sure to try and work on the psychometric properties and make sure it's, has validity. But I'm guessing Rachel's face, I'm thinking it has some. I have not assessed it, but yeah, so we'll talk a tiny bit about that tomorrow. But Rachel, thank you so much.